Welcome to the LowCarbMD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome back to the Low Carb MD podcast. This is one that we don't, Tro and I aren't like little kids very often get really excited, and this is really something. I mean, we have a legend, someone who we really respect a lot, someone who's given us courage to stand up and stand up against the giant sometimes is really, really tough. Tro, this guy, we talked about you last night. We said if we do all of his credentials, like the whole podcast will be over before we can even do the podcast, right, Tro?
Yeah, basically a consultant cardiologist out in Britain, author of the Pioppi diet was your first book, right?
That's correct. Yeah, absolutely true. Yeah.
And then this book, which is fantastic. Okay, A Statin-Free Life. I'm majority of the way through it, and it is fantastic. And the reason why I'm excited, it's not because he's a great author. It's not because he's a cardiologist. It's not because that he pushes back on the dogma from pharma. He pushes back on the dogma from other doctors, and he's just a vehement fighter. Somebody who's inspired me. If you have not seen his videos going against AstraZeneca CEOs, watch them. If you haven't seen his videos from the news, go and watch them, because this is what every doctor needs to be like. I cannot say this again. Dr. Malhotra, I am so happy to be here with you right now. I cannot tell you how happy I am. We were just talking about this off the air. It's lonely fighting this fight, and it's good to connect with people like you.
That's really kind, Troy. No, I appreciate that a lot. I think for me, I kind of lose perspective on what's happening externally with what I do often, but I just always stick to the basic principles of, am I doing my ultimate duty to the patient? For me, that's what drives me, right? And that often has meant that you have to challenge bad practice. You have to, speak out against the what I call the commercial determinants of health that ultimately harm the patient. So that's really where I come from when I do all of this work. But no, it means a lot that you say that, because it can be a lonely path when you're kind of trying to lead a movement or being one of the leaders of a movement. And what sustains me is support and comments like you've given me and what my patients give me.
I was just telling Brian before yesterday when we were talking about this interview. First of all, he's like, man, I'm a little intimidated. He's like, everything embodies everything I want to be, the courage, everything. And I was saying to him, you are my power animal. When I watch you talk, when I watch you, simplify, very complex thoughts in medicine and in policy, and when I see you do it, it gives me courage. One, you give me courage to keep doing what I'm doing, and you give me courage to do even better, to be even louder, to be even more focused on lifestyle and the power of diet, the power of, the power of transforming your whole life rather than, necessarily taking meds. And what I love about you is the way you approach in your book, Statin-Free Life. It's like you acknowledge that these medications have some role, right? They have some role.
Yeah, absolutely.
But you outline a way out. And, and it creates hope, and it creates, it helps people understand, the chapter on reversing, can heart disease be reversed? I just loved it. I loved it. I just wanted to let you know that. So
that's really kind. No, thank you. And I'm hopeful. And I know this is, by the way, this is the first US podcast or any kind of media I'm doing on this book. So this is great that I'm able to speak to you guys about it. And I believe it's out in November the 16th. It's out in the US. So hopefully, I'm really, really pleased that you liked it, because I know we haven't communicated since the book was sent to you. So, the fact that it's resonating with you, for me, gives me a lot of hope that many people, hopefully doctors and members of the public in the States, if they're able to read the book, it will have an impact on them.
Well, here's the thing, and I wanna take a step back. I want to discuss the book. I want to take a step back because I'm sure you went into medicine with the noblest of intentions. Along the way, how far down to drinking the Kool-Aid did you get before you pulled yourself out? Because I was a 350-pound doctor in the Yale system drinking the Kool-Aid, and I want to understand your origin story. How did you get to be the person you are now? How did you get to be this courageous person who, without flinching can blast pharmaceutical CEOs?
Yeah, it's a great question. It's a great question, Cho. I think that for me, a lot of the way our personalities are often shaped by our upbringing. I was very lucky and fortunate to have two wonderful, very kind, loving parents who were both doctors, so both general practitioners. And I think my values in relation to what you're talking about really came from them. My mom was just a very kind, compassionate human being, probably one of the most compassionate people I've ever known. And obviously, a lot of people say that about their mom, but genuinely, she was like that, and everyone that knew her thought that of her. And my dad was somebody that I think was quite a rare person that combined having very high integrity, but also being very wise and intelligent and being compassionate. He had those rare sort of combination of attributes. And also someone that wasn't afraid to speak truth to power. I learned as I was growing up hearing stories from his friends that he at one stage was imprisoned in India, calling out government corruption at the time of Indira Gandhi being the president. And that was the kind of guy, and he was a junior doctor, he was a doctor's leader, all that kind of stuff. So I think some of it certainly was passed down to me. They led by example. And I feel that they've unfortunately both passed away prematurely in the last few years, which has been very tough. But at the same time, I also feel fortunate I had such great parents. So I think for me, my personality certainly has been shaped by them. And my dad always encouraged me to speak truth to power. And I think once I decided I was going down the route of being a doctor, which I loved, like all of us that go into medicine, we love the scientific aspect of it. We love the problem solving, making diagnosis, and of course, seeing the impact of that on our patients and how that feeds back into us. It gives us a job satisfaction. And I think for me, having done all the conventional stuff and trained initially as a cardiologist and an interventional cardiologist, I was fascinated by coronary artery disease. I wanted to be the guy in the cath lab putting in stents and doing all the keyhole heart surgery stuff, which I loved, and certainly treating the acute cases was particularly satisfying. I gradually, having graduated in 2001 as a doctor, by the time we got to about 2010, what I noticed, Tro, is that just from my own experience on the front line in the National Health Service, I was seeing more and more stress on the system. I was seeing more people with more chronic disease, more weight-related issues, more misery. But it was also how that reflected on us working as doctors in the hospital and with the nursing staff. I could see more strain and more pressure. And that's really where I started to kind of see that, we were doing something wrong. Because if with all the modern medical science, all the awareness that we have, all the technology, all the advancements, if we were doing everything right, patients wouldn't be getting sicker. We wouldn't be having this problem. So for me, it was initially started as a bit of a curious sort of investigation, trying to figure out what was going on. And it didn't take long for me to realize that most of this was being driven by lifestyle. And then it became almost like an investigation to figure out, well, actually, are the drugs really helping? How good are they? How effective are they? Not just about.
Can I pause you here for a second?
Yeah.
You mentioned you went down the rabbit hole of kind of learning about lifestyle, and certainly about the food. But when they promote kind of lifestyle interventions, it's, you said you understood the impact of lifestyle. It was kind of, easy for you then. I mean, they were saying eat low fat, you mentioned even the Dean Ornish studies in your book, and this was the prevailing thing at the time. I'm thinking about 15 years ago, right? So,
yeah.
And then you call that, then you had the courage to call out like the fast food that's in the that's associated with your hospital and the vending machines and all that. Like, what are we doing here, guys? This is ridiculous.
So what? I mean, something happened. I mean, now you're promoting. I think you're driving the what is it? What's that organization? The Public Health Collaboration, right? So help me understand. Which is very pro low carb. So you're a cardiologist who's, you know, in this like dogma of low carb, low calorie, eat less, you know. So how do you, and you're too, you know, I'm sure as smart and as compassionate. I want to say I'm sorry about your father's untimely death and your mother's death. I know you got hit with 2 deaths in the past year. I'm sorry about that. As smart and compassionate as they were, you know, did they know what did they know and what did they pass on to you? And then the system make you think about lifestyle, and how did that change?
No, Troy, it's a really good question. So I think coming back to, again, the personal interest area, I think for me, I was always a foodie as well. So, you know, I think all these things are kind of linked in terms of what drives a curiosity. And so I was somebody that, you know, I learned to cook when I was 16. My dad was an amazing cook. My mum was a great cook, but my dad, you know, I'm sure we had discussions about this. I don't think my mum would mind, wherever she is, rest in peace. But my dad was an amazing cook. And I learned to cook from him, and I enjoyed cooking. So I became basically someone that would end up, even when I was in university, I was known as having the best chicken. You know, I'm Indian origin, so people would, you know, come there. I had this reputation of cooking the best chicken curry in the medical school, and we'd have these parties, and I'd cook this big cauldron of chicken curry, and people would come over and that kind of thing. So I was always
who could eat the most American pizza. So, you know.
Well, listen, I love pizza too, but we'll come on to that in a second. And so I think there was, and I realized there was an enjoyment around the food, but there was also, and I didn't mean I didn't eat junk food. I mean, I was addicted to sugar. But I started off as a foodie. And then one of the things that initially triggered me to kind of link together, if you like, put the jigsaw together around the hospital food situation. So as you know, in the States, in many hospitals, and probably most hospitals, certainly most hospitals in the UK, we've got the statistic that 75% of the food purchased in hospitals is essentially junk food. And 10 years ago, when we were getting this awareness about the obesity problem, which had been around for a long time, and nothing really effectively had been done to combat it. Because every year we get these headlines and these statistics like Britain's obesity epidemic, you know, 1 in 3 kids overweight or obese by the time they're 11 years old, 60% of the population overweight or obese in adults. And this was still getting worse. I was like, geez, you know, and we were then feeling all of it on the front line. One of the things that occurred to me when I looked around, and partly also for my own irritation as someone who's a foodie, when I'm working my shifts and my own calls, and I go to the canteen, you know, I go to the I don't know whether you call it canteen in the States, so, you know, where you get your, you know, the food basically that's served to patients and
cafeteria,
exactly, cafeteria. It was terrible. I mean, it wasn't, you know, when you're stressed and you're busy, you want to eat good, nutritious, healthy food, right? I was already on that kind of path, and I was irritated initially. I was like, this is ridiculous. You know, so I then ended up bringing my own food in and stuff. But then I also looked around at staff, nurses, doctors. We had also a statistic that more than half of doctors and nurses in the National Health Service are also overweight or obese, right? And once I'd figured out, looking at public health and speaking to experts and reading a lot around this topic, I realized obviously this was predominantly, you know, what drives our eating behavior is predominantly environmental. Of course, we can do things like, Joe, you've done an amazing, you know, many patients that have had great stories about how they've transformed their lives, but it is much harder when the food environment's working against you. It's much harder to sustain it. People can have, you know, the willpower for a certain amount of time. But as you know, this is, I'm sure, a topic you know very well. If you look at data in terms of whether it's low fat or low carb, I mean, low carb obviously does better. People fall off the wagon. And my view, the reason people fall off the wagon after a year or two or a bit longer is because actually, if you look around you, most of the food that's available, there's a predominance of this ultra processed toxic crap, basically, pardon my language. So I realized that we needed to improve the hospital food environment. And that's where things started to change for me. In terms of, there's a great story, which I've mentioned before, is one of the things that kind of got me thinking was, I remember treating this guy in the middle of the night for emergency stenting for an ST elevation myocardial infarct. So for the listeners, complete blockage of one of his arteries, keyhole heart surgery, treated him, saved his life. And then the next morning on the ward round, when I'm having a conversation with him about, taking his pills, including, by the way, his high dose statin religiously, and telling him that stopping smoking was the best thing he could do to improve his lifespan, better than all the pills that combined. So I was already had an interest a bit on the public health side in terms of smoking. I also said to him, listen, you need to eat a healthy diet. And as I'm telling him this, he gets served a burger and fries by the hospital. So the hospital is then serving a burger and fries. I thought, well, and he actually says to me, he says, Doc, how do you expect me to change my lifestyle if you're serving me the same crap that probably brought me here in the first place? So, it was just such a mess. And I thought at that point that I needed to do something about it. And the way things sort of went, that's where it kind of started for me. Then I decided shortly after this conversation with this patient, I decided that I was going to email Jamie Oliver. So I think you're aware of Jamie Oliver in the States. He's this famous chef. And I had been inspired by the fact that he'd made attempts to improve food for children in schools, because same sort of junk food was being served in schools, a lot of starchy carbs, sugar, that kind of stuff. And I actually thought, Jamie could maybe start a campaign to get hospital food improved. So I wrote an email. A journalist friend had an email address of his PA. I didn't expect a reply, but 6 weeks later, I get this response saying, Jamie would be thrilled to meet you. Why don't you come over to his office and have dinner with him? And I was like thinking, wow, okay, this is interesting. So I went to meet Jamie. He'd invite some other doctors who were interested in solving the obesity problem, some very eminent doctors. And I was a little bit out of my depth because I was probably the youngest guy there. But I thought, I'm going to just enjoy this and going to talk and engage with these people. And as you probably know, as doctors yourself, when you're a relatively junior doctor, because I was still, we call it specialist registrar here. So one rung below sort of reaching the pinnacle of your speciality. I don't know whether you call it attending in the States.
Yeah, it would be like a fellow, like not a resident, but a fellow.
Well, exactly. So I'm not like the boss. Yeah, exactly. So I'm then sent, and I'm sitting amongst all these very, 2 or 3 very eminent, chair of the Royal College of Pediatrics and all these kind of people. And I'm there kind of, but, maybe partly I was the only obviously person with interested in heart disease and cardiology and who was there, because most cardiologists, it won't surprise you, are not really interested in obesity. I remember when I was in my own hospital talking about sorting out the prevention side, and I'd by this stage written an article in a very prominent newspaper called The Observer that they put in the front page, even though I was a junior doctor. So you can imagine how certain people may have, there's a certain culture in medicine, unfortunately, where, junior doctors making big statements, can maybe upset a few egos. I think you know what we're talking about. So anyway, you can imagine that was obviously a bit of a like, oh, okay. Yeah. And I remember being told by one of them, half jokingly, Aseem, why are you interested in prevention? This is a cardiologist, by the way. You're going to ruin the business, right? So I just thought, it's crazy. So when I,
business, I'm sending people in the middle of the night,
Well, exactly.
For 1 second.
Well, exactly.
Well, I want to pause for 1 second because it was the patient who gave you the answer. Like, how they say a history will give you 90% of the answer in medicine. Yes. I don't know if you guys know, this is like a comment.
Absolutely.
Listen to the patient. 90% of the answer is through their story.
100%.
He is literally feeding you the answer. And you're like, this is the position I found myself. You were literally beyond trained. You're beyond trained. And it's a heart attack patient who literally fed you the answer. Isn't that amazing?
Yeah, absolutely. Absolutely. And some of that as well, Tro, is that I also realized that, as you know, most doctors get no training in nutrition. And certainly, as far as I'm aware, there's very few medical schools in the world where they've linked the nutrition to chronic disease, because the traditional, whatever teaching we get in medical school around diet and disease is all usually around diseases of deficiency, pellagra or whatever. And it's about malnourished patients in hospitals, and dietitians are there that were predominantly, they were employed to kind of help, malnourished patients or post-op patients to just get enough calories into them, right? So there was no connection between the food and chronic disease. So that's been the old traditional model, which still exists to some degree, right? And that's where there was a challenge. And then the other side of it is most cardiologists, certainly most doctors anyway, wouldn't. I think one thing that occurred to me when I started looking at the research early on is I found papers which showed that the effect of dietary changes on cardiovascular risk were rapid. Because of obviously all the focus on obesity, you know, it was about the traditional calories in, calories out. So there's obviously another discussion there about appetite control and how that's evolved in terms of it being more of a hormonal issue. But as a cardiologist, what fascinated me most was actually, hold on a minute, if dietary changes can rapidly reduce cardiovascular risk within weeks to months, shouldn't we be starting in the hospital when the patient comes in with a heart attack? You know, why not then put him on a diet which may be anti-inflammatory or traditional Mediterranean, but as obviously we've evolved, you know, taking away the pasta and the bread now. But, you know, at the very least, it should be something that is whole food. And that wasn't happening. So that when I looked at that, and it was very compelling and it was good quality research, I said, okay, well, now I need to kind of start being a champion for that and getting that information out there.
Yeah, I think that's another. Oh, go ahead, Troy.
No, go ahead, Brian. I've been yapping away.
Yeah, I think it's an important thing because, you know, when you look back, you look at what we call it grand rounds here, and you say who's sponsoring the grand rounds for the nutritionists, for the doctors, for the residents, it's all funded by pharma. That's where the edge is. Like, no one's paying that. I'm not going to pay someone to go talk, right? So I think that's a we have a huge conflict of interest. And I think someone like you, who, when I first heard about you, I'm like, oh, this guy is crazy. He's crazy. He's standing up, really, because you're standing up to pharma. That is a machine. We're learning that now more and more. When you stand up to the machine, you better have your facts. And, you know, because I know whenever you go on the media, it's not that they're there because they like you. They want to tear you down, right? And then when you stand up and go, no, here's the data, here's the facts, here's what it is. And people say, well, this guy's respectable. Common people who listen go, this guy makes sense.
Yeah.
Right? And you're not selling them something either. And I think that's a big, huge point.
Yeah, and Brian, it's a good point you make around you know, the use of the media in this. For me, you know, I, as well as a clinical clinician, I'm also a campaigner or a change activist, and all of my understanding, if you look at really what we are all trying to do, really is revolutionize medicine, right? To be more focused on lifestyle and to be more judicious and more honest when it comes to prescribing medications, right? And for me, I felt that there was once, you know, I'd put the jigsaw together and really realized what was going wrong. All this corporate influence that was you know, too much power amongst people that are trying to sell you something, as in the drug industry, for example, the food industry, that were putting private profit before health. For me, then, in very basic terms, that translated into a gross injustice, as in a gross injustice that's happening to my patient. So what do you do? What do people throughout history, when you're trying to create a kind of revolution or change things, one of the things you do, whether you know, and I'll be very honest, I talk about some of my inspirational figures, whether it's Mahatma Gandhi or Martin Luther King, is that, you know, what they did is Gandhi said, what do you do in these situations where there's a gross injustice going on that's affecting many, many people, okay? Certainly in the world, right, I say most people are being in this gross injustice when it comes to the health information they're receiving and what they're making their decisions on about their health, is you make the injustice visible, or you try your best to make your injustice visible to change things, because most people want to do the right thing and most people want to be empowered with the truth, right? We all want the truth. And the best way, or the best platform, there's many platforms, but if you can, and I've been fortunate enough to get that platform over time, although I've had to hammer away hard to get that platform, or there may be, I have to maybe try several times on one particular topic sometimes to get something in the mainstream media, is actually through the mainstream media. They still have the biggest reach and biggest impact. And of course, we've got social media as well, and I think that definitely has a positive and sometimes a negative role. But once you make that injustice visible, then change happens. And then over that period of time, over the last 10 years that I've been this campaigner, one of the things that I have learned, and certainly I feel that I've had some success with, was bringing about the tax on sugary drinks, or at least raising awareness about the harms of sugar. And that started off through writing in medical journal. Then it was something that then hit the mainstream media. And then I was, able to then convey that message in a way that then had impact, and then it took its own sort of, it went on down its own path, and politicians got involved, and people realized it was an issue, and before you know it, a relatively right-wing government, which you wouldn't have expected to happen, suddenly say, well, we're going to bring in a tax on sugary drinks, or sodas, as you say in the States. So that's really what I kind of, once so there's one thing, you've got to get the science right, of course. You've got to be as certainly as best as you can, because science is constantly evolving, and of course we have our own biases. But how do you translate that science into something that's meaningful for policy change that then can impact on many, many people's lives? But in the process, Tro, you mentioned it earlier about taking on big pharma. I think one of the lessons I learned about public health advocacy is that you need to grow a rhinoceros hide, because soon as your work threatens an industry or an ideological cabal, you will be attacked, sometimes relentlessly and viciously. And I learned that from, there's a great paper that people can read. It's not a long read, but it gives you the tools with whatever you're doing that you feel passionate about and you think needs to get out there in terms of, an honest conversation or getting the truth out there. It's called Lessons in Public Health Advocacy, written by a professor of psychology in Australia called Simon Chapman. And he talks about his 38-year career as a public health advocate and being really the lead campaigner to get tobacco control instituted in Australia. And that's one of his lessons. He says that you need to grow a rhinoceros hide. So he, started off in this journey where he was highlighting the harms of tobacco and taking people on, but he was attacked in a pretty nasty way. And he said, you've got to be prepared, and that's going to happen. And in relation to that, somebody else I just want to mention as well that I found very interesting and inspired by in terms of his approach to things, and I know he's a controversial figure, but maybe you guys like him, hopefully you do, is the clinical psychologist Jordan Peterson. And I saw a recent talk of his. He talks about speaking the truth. And he says that we have to all understand that it is not safe to speak. Okay, it is not safe to speak the truth, but especially if you're taking on big, powerful vested interests. But, he looks at it more philosophically as well. He said it's even less safe to not speak, because even if you're avoiding a conflict in the short term by staying silent when you should speak out, you are ultimately causing more damage in the long term, because it will come back to you. And if it doesn't affect you, it's going to affect your kids. So I think this discussion we need to have really with people that maybe feel afraid that actually they do need to speak out, because if they don't, we all suffer ultimately.
Can I talk about this? Because here's the issue. Right now, when I view, I've commented a lot about our colleagues, our industry, as one of the biggest barriers to a patient escaping obesity. Okay, for a patient to escape obesity, their biggest barriers are their doctors and their dietitians, number one and number two. Okay, because they will not guide them the way they need to be guided. Number three is the food industry, right? Now, but you can manipulate the food industry. It's much harder to manipulate a doctor, right? To change his beliefs or to consider beliefs that don't agree with him. You can go to McDonald's and you can get hamburger patties. You can get chicken patties. You can get a salad, right? You can get a lot of them, as much as you need to not be hungry, right? So you can use food companies who have been targeting you your entire life. You can use them back. Doctors, it's much tougher, right? So, and then the other layers, big pharma, and big pharma has done an amazing service to humanity by looking at drugs and vaccines and doing. They've done a service to humanity, but at the end of the day, they want to sell more. So they will abuse their research, or they will, the marketing people will make things, seem much more beneficial and much less harmful than they probably are. Right. So again, you may be able to use them, you may be able not be able to use them, but these are the main villains in this, and then to some extent government and their public health messaging.
Well, yeah, and I think the other big problem really is that us docs, we are rule followers. We're told something, we follow the rules. We want to be in the middle of the pack. You don't want to stand out. You don't want to say, hey, I'm going to question. Everyone knows that statin drugs save everyone's life. That's what the belief is. So if you take someone off a statin, they have a heart attack, go, see, that doctor caused that. So there's liability. Sure. There's a huge amount of liability. You look at what Dr. Fetke, who I respect a great deal, Tim Noakes, what they went through, because they knew they had the facts, they had the data, and they had the clinical experience. So it's a hard thing. In doctors, I'm telling you, I was just telling Tro before we started recording, I have 5 doctors that I've talked to personally that I've communicated with, and they go, love to come on, but I can't. My hospital won't let me. I have to clear it. I have to tell every subject, here's the stuff I can talk about. Here's what I can. It's like, wow, that's just scary when you have doctors that are muzzled like that.
Absolutely.
That's so
And we actually, Brian, we are in a way, I understand these problems. I've had my fair share of attacks, not just behind the scenes, that's a story for another time. Lots of stuff behind the scenes going on, but even in the public eye, at least twice on the front page of 2 British newspapers, I've effectively been described as being dangerous or a murderer. Okay, front page of 2 British national newspapers in relation to the statin stuff. So I've had my fair share of that. But I think that we also have to think very deeply about that staying silent, we are ultimately in dereliction of duty to our patients. We are. Now, and that's why I think people like us getting together, the network, safety in numbers, creating that movement, I think is so important. But it does take courage. It's not easy. And doctors intrinsically by their nature are not people necessarily that are going into medicine to pick fights with big industry, right? We are here just to, often follow the rules and look after the patients, rules that we know are now outdated, or rules that are unjust, or rules that are just basically wrong and need to be changed. But once you have that realization, you then have to make a choice. Are you going to stay quiet? And are you going to be somebody that, 10, 20 years down the line, you look back and think, I regret just staying quiet, and what kind of person have I become? Or are you going to be somebody that your kids are going to be proud of? Recently, when my dad died, I was, he was such an amazing figure that I thought I couldn't do justice to him in a eulogy. And when I started the eulogy, and I spent a few days writing this, one of the things I remember he saying to me, and he was talking about when he was speaking, he was a medical leader. He was speaking to other medical leaders. He was the first sort of non-white, if you like, or Asian deputy chairman of the British Medical Association. And he came from India. He still had an Indian accent, right? And to go up in with all of that and to become, part of the establishment, but also always speaking truth to power was quite unusual. And one of the things he said, he told me that in a meeting, he said that when your kids think of the word fairness, the first thing that should come to their mind is you, their parents, right? And I think in in the UK, we have something called the Nolan Principles, which was, there was a committee of standards in public life that was set up many years ago under a previous prime minister called John Major in response to a cash for questions scandal. Now, I know in the States, I think, you're allowed to, industry are allowed to pay and finance politicians and political parties. It's not that clear cut, certainly in the UK. It's probably a bit more, subtle, but essentially you're not supposed to be doing that. You can't pay a member of parliament or a congressman, if you like, to an industry can't pay them to go and ask specific questions on their behalf to change rules and regulations. And there was a scandal, and then it got exposed, and then this committee of standards in public life came out, and they gave these mandated recommendations called the 7 Nolan Principles, which applied to doctors, teachers, police officers, the fire brigade, people who had a duty and responsibility to the public. And those 7 Nolan Principles were that we should all act with selflessness, integrity, objectivity, accountability, honesty, openness, and leadership. And that's really, for me as well, I think we all have to also think about, what are we doing? Are we actually adhering to those? Can we look in the mirror every day and say, actually, today I was somebody that every day in my practice, I'm adhering to those principles. And as soon as you realize that you're not adhering to the principles, there's something very, very, very wrong in the system. And of course, this system actually is a hindrance to people actually doing the right thing, because there's so much money in the wrong place. It's a profit-driven healthcare industry around the world. It's becoming more like that in the UK. Of course, we know it's a big issue in the US. I don't have any, I know there are many brilliant doctors and many brilliant things that go on in the United States. I have relatives and friends and doctors in the States, and I visit all the time. But when the system gets, when you bring money, the profit motive into healthcare, it's not compatible with giving patients the best deal.
When I think, you brought that to light, I just saw your video that you did, your interview talking about the vaccination data. And you said, look, here's the data. Here's maybe you can give a little history of what Pfizer's paid out in fraudulent payouts and all these things over the years. And you say, now you give 100% trust to this person. Anyone who questions that is blackballed. And that's a problem, because we have to look at the data and we have to look at the results, and we have to trust the results too.
Yes. Absolutely, absolutely, Brian.
So,
And
the problem is in the media, no one's talking about this. It is unbelievable that you even got to talk about it, actually. But tell the Americans and the people out there listening what you're talking about.
Yeah, so I think when you look at the history of the pharmaceutical industry, well, first of all, Troy, you mentioned earlier also about there are some myths that we need to bust. So I've got an affiliation with Stanford, something called the Metabolic Psychiatry Unit. So there's a unit, there's a psychiatrist there called Shabani Sethi, who's very interested on the impact of food on mental health. And I've got some honorary role with them. So, a couple of years ago, I had the honor and privilege, I'll be honest with you, it was a real honor for me to be invited to speak at a grand round, in the medicine grand round at Stanford. And it was medical students and public health students and a few professors of medicine there. And one of the things I talked about at the beginning is I had to dispel a common misconception, which is even amongst doctors, as well as members of the public, is how much has modern medicine contributed to our lifespan over the last, say, 150 years. So if you look at the United States, in 1850, the average life expectancy was 40 years old. Now we're roughly around 80. So of that 40-year increase in life expectancy, they did a study, and you can look up this study as a survey, and they took they took educated adults, actually, if you like, and they asked them, how much do you think of those 40-year increase has modern medicine contributed? And 80% of the people said 32 years. So they said most of the increase in life expectancy is because of modern medicine. Nothing could be further from the truth. At best, about 3.5 of those 40 years, well, 3.5 to 5 years of the 40 years is because of modern medicine. And those are for things like, Troy's mentioned before, vaccines to some degree, acute treatments, antibiotics for infections, development of coronary care units, emergency heart procedures, that kind of stuff. So the acute stuff is really where we have helped increase life expectancy. But most of that increase in life expectancy in the United States has happened through public health interventions. It's like safe drinking water, seatbelts in cars, smoke-free buildings, safer working environments, better sanitation when it came to food. So a lot of people were dying from foodborne illnesses. Now we've got, food that you're unlikely to die from the food as in acute infections. But the food obviously has another problem with chronic disease, as you know. But that was something that was very interesting. And, and I don't remember maybe that being very prominent in medical school. So you've got this prevailing kind of narrative to start with. Then it's exacerbated by the fact that 80% of the mainstream media in the US is controlled by about 7 corporations, big corporations. So the narrative that's going through the mainstream often is the narrative of those big corporations. The very corporations that are sequestering the truth when it comes to health information in many ways, And then you look at what have the pharmaceutical industry been doing for the last sort of 2 to 3 decades? So Marcia Angel, the former editor of the New England Journal of Medicine, she gives a great talk, and she, explains that between 2000 and 2008, slightly old data, but it hasn't changed very much, of the 667 drugs approved by the FDA, only 11% of them were proven to be truly innovative, as in better than the previous drug. So what happens is the drug industry put out these industry-sponsored studies, they get their press releases out, they change guidelines, and they have a patent on these drugs. And by the time someone's figured out with an independent study a few years later, this drug is no better than the previous drug, they've made their money and they move on. When it comes to corporate criminal activity, between 2009 and 2014, most of the top 10 pharmaceutical industry companies paid a total of $13 billion in fines for criminal activity, which included illegal marketing of drugs, hiding data on harms, falsifying research results. I mean, and nothing has been done to change the system. GSK, paid the biggest fine in 2012 in history, $3 billion for illegal marketing and hiding data on harms on several drugs. And guess what? They made $25 billion during the period covered by the settlement from the sales of these drugs. No one got fired. No one lost their jobs. How do we expect this to change? They are there they are there to make money. They are not there. They have no legal responsibility to give you the best treatment. So this is a problem in the system. But ultimately, I have concluded that if we're really going to improve the system, we need to actually change the law. These are laws that are unethical, unjust, and undemocratic. If you told most people, most members of the American public, do you think this is acceptable? I can guarantee you almost all of them will say no. So this is not democratic. So the fact that they're able to get away with this means there's something wrong in the system, and that ultimately means we need to change the law.
So can I talk about a couple of things? So first thing that you brought up here, okay, is bringing to light the enemies, right? Bringing to light the enemies. But the enemies are ubiquitous. Government, industry, food companies, pharma, and doctors and dietitians, right? Ubiquitous. These are our enemies. So
well, yeah, and I think along those lines, you look at the FDA advisory panel, and you look how many were previously worked for Pfizer or are going to Pfizer, and you look, you go, that's like me saying, okay, Tro, I'm going to approve all your stuff. Okay, you approve my stuff, I got you, and that is unethical.
This is a mindset. This is a
massive problem.
Even the mindset is biased. So that's one issue. Now, second issue I have, and help me understand this, is, you have these pharmaceutical companies. You talked about the fraud in the industry. Let's talk about what's not even fraud. You mentioned drugs not being any better than the prior drugs. Well, they take it a step further. They reformulate them. They make them an enantiomer. They put them into a special coating. They make them extended release. So there is a multi-billion-dollar industry through extending patents, through reformulating. It is truly the biggest waste of money we've ever seen.
Absolutely.
Now, so there's a whole nother, and this is completely legal, right? And it's not, this is completely legal. So, but now let's take the flip side. And I want to focus on statins because your book is Statin-Free Life. It's about statins. And I want to, if you'll entertain me, I want to talk about a patient I recently saw.
Yeah.
Okay. I saw a 55-year-old patient, had some family history of heart disease. Okay. A father or mother, I forget, with early cardiac death, had a bypass. I sent him, to get a coronary artery calcium score. Now, that we didn't acknowledge these calcium scores for over about 15 years. We didn't acknowledge the utility of them. And there's a whole story about why we never acknowledged the utility of them. But I sent him. And this patient came back with a low score. So previously, in another life, probably when you graduated and became a cardiologist at first, the advice for him would have been, well, your cholesterol is 150, your LDL is 150. We use milligrams per deciliter. I don't know if you guys use millimolar or what you guys use, but
millimole, but
the number's too high. You have to take a statin. So I sat down and I reviewed the old guidelines in him, which were number-based. If it's above 160, start a statin. And I said, let's look at today's guidelines. What do they say? So I opened up the 2019 AHA ACC guidelines. Okay. And I went through with him, and basically the guidelines now say, estimate his risk of death.
Yeah.
Estimate his risk of death.
Yes.
So I estimated his risk of death, and it was low to intermediate. Okay. It was low to intermediate. His diabetes was resolved.
So less than 15%, something, whatever. Yeah. Less than 15%.
Yeah. So his 10-year risk of heart disease, if you take into account some of the risk enhancers, and you take into account the fact that he lost 100 pounds, he's out of diabetes, right? He's in a low to intermediate risk. Let's say if you use the MESA 10-year risk calculator, if I'm trying to estimate his risk, it's somewhere between 7 to 12%.
And that's with obviously with the calcium score accounted for. Yeah, absolutely.
Yeah, a little bit of calcium on it.
Yeah.
And so he asked me, well, what should I do, doc? And you know what? I told him, I don't know. Even by the guidelines, guidelines, it said favor using statin.
So do you know what do you know how I approach this, Tro? So I get this all the time. So when you look at the just very briefly, there's a great concept called the evidence-based medicine triad. Okay, so David Sackett, the father of the evidence-based medicine movement, over 20 years ago now, produced this. It's in the BMJ. You can look it up. It's great. It's a very simple, elegant slide which basically puts three components together in order to improve patient outcomes. So the doctor's individual clinical experience, okay, best available evidence, and then patient preferences and values, which he says is the most important. I agree with, right? So that's what we're here to serve patients. So what does that mean? Well, so if you look at the best available evidence on this particular question about statins, forget about cholesterol for a second, about risk, treating risk. we know this is indisputable. If you have a less than 20%, and this is, by the way, still from industry-sponsored trials, so it's best case scenario, almost certainly. If you have a less than 20% risk of having heart attack or stroke, this is what I tell my patients. I say there's an approximately 1% chance, okay? So this is what we call numbers needed to treat, as you know, one absolute risk reduction, 1% chance over a 5-year period that a statin will prevent you having a non-fatal heart attack or stroke.
That's exactly what I said. That's exactly
but will not
what
prolong
I said.
Brilliant, but will not prolong your life by 1 day, okay? So I put that to them, and then without even mentioning side effects, and then I say, how do you feel about that? But do you understand what that means? And then we talk about it and says, well, how do you feel about that? Do you want to take a statin based upon that information? Almost always, Tro, they say no. And then I write to their general practitioner, whatever else. And this is, I make it very clear in my letters. I said, I explained this to the patient, and in keeping with the principles of ethical, evidence-based medical practice, the patient has decided that they do not want to take a statin, and this should be fully supported. That's it. Now, one of the challenges I've seen, having looked at this is called shared decision-making, right? So this is how we should be practicing medicine, and we can do NNTs for so many drugs, and we involve a patient. Patients love that. They want to be empowered with this information. Of course, we also, as you guys know, because you're much more aware of this than 99.9% doctors, there's also an alternative as well, right? There's a lifestyle thing they should be thinking about the diet and all that kind of stuff, which we throw in there. So it's not that they're just going away with that information. That's the end of the conversation. There is something else they can be doing. But one of the things I found, and it's something you probably want to look into, I looked up, there's a legal, there's a paper that was written about shared decision-making in the United States. And from what I understand, Tro, which again, I think is pretty shocking, is that actually you're potentially liable by giving patients the full information if something was to happen. And I think that's a big problem, right? And I don't know how it works in the States, that if you are not following a guideline, which is very clear, saying you must prescribe the statin without having this discussion about true informed consent, is whether you then would be potentially liable. And that's another barrier in the system. And I have no doubt this has been, again, influenced by the corporations to actually infiltrate the legal aspects of these discussions to bias in favor of prescribing versus actually having an informed discussion.
Well, so,
I think you raised that issue too. Like, there was a video you did. I can't remember what it was called. I think it was like License to Kill or something like that, where you were testifying and saying, look, all this stuff that's happening that's actually malpractice. When you you raised the issue of
I think it's unethical.
Bush getting stented after doing.
Do you
remember unethical. What the name of that for people to watch on?
I can't. Well, actually, no. So I spoke in the European Parliament, and
yes,
in fact,
exactly.
if you look up, there's a talk. So it's called "Big Food and Bad Pharma: Killing for Profit?"
Killing for profit. That's what it was. Killing.
So I was
for profit,
allowed to actually use that title and speak in the European Parliament, and it got coverage in Belgium, and it had a lot of views. So yeah, no, if people want to look at this whole picture, then they can look at that talk, and I talk about this. And yeah, in my view, to not give patients the full information is unethical, right? If they're making clinical decisions and you're giving them half the information, or not allowing their preferences to be taken into consideration, it is completely unethical. I mean, I've given this similar talk in Seattle. I've given it to doctors in New York. I've done tours around the States where I've gone to grand rounds in hospitals, and I've said this very clearly. And maybe that my American friends are being polite with me because I'm the British visitor, but no one has challenged me on it. When I've said this is unethical, somebody put their hand up and said, "Doc, what are we supposed to do?" I said, "This is unethical," and no one has come out and said that it's not unethical. They agree with us. They agree with me. So there's clearly a system failure there, isn't there? There's a system failure there. Every doctor gets it. Once you explain it to them, they get it.
Yeah, and I think that's a big. Let me just maybe one more point before because I'm ultra, I'll forget. But there's a big thing. We all got a letter from our medical board here saying, if you speak negatively about the vaccination, we will come after your license. And I say, well, if I need to talk to my patient about risk and benefits, I need to explain, here's the risk, here's the benefit, here's the potential. There's 1 in a 10 billion chance that you could have paralysis. Then I need to tell you that. But by challenging my license to give informed consent, where have we come in medicine?
Absolutely. It's crazy. I mean, on the vaccines, very briefly, this isn't, one of the things which I think is very interesting, that people, you can actually do there's a risk calculator now for COVID in terms of age and your background history and that kind of stuff. So one thing I looked up, which I didn't mention on GB News recently, but was really interesting. So of course, there's a huge mandate to vaccinate kids across different parts. I know in the States, there are certain states that are saying yes and certain states saying no, whatever. And then it's a parental choice to some degree, which I think it should be. So I looked up, so if you're a healthy 19-year-old Okay. What do you think the risk of dying from COVID is if you're a healthy 19-year-old? Well, just I'll give you the answer.
It's 0.00.
Yeah. So 1 in a million.
1 in a
One in a
million.
million. Okay. Now, guess what the risk of dying from the flu is if you're a healthy 19-year-old? A lot higher. It's about a lot higher.
Yeah.
Right.
Or dying in a car accident, or dying in.
Yeah.
Like one in 100,000.
Why don't we have this discussion? Why don't? Yeah, it's like 1 in 300,000, something like that. It's much small. So, we need to give that. We have to have the debate and the discussion. I'm not saying it's the end of the discussion, but for me, it doesn't make sense then, especially as we know the vaccine doesn't have any significant impact on transmission. You could still argue the case to protect older, vulnerable people, vaccinate as many people as possible to protect them. But now we know it doesn't really do that. Why are we vaccinating kids? Why are we putting all these resources into vaccinating children? It doesn't make any sense to me. I'm sorry.
And why are we not testing them to see if they've been previously infected too?
It makes sense. The only way it makes sense, okay, is if doctors are largely automatons, people have noble lives, people in power spread noble lies, which is, get vaccinated, protect your grandma, okay, and industry profits. That's the way it happens.
Absolutely.
Right. This is the cycle, and this is why people understand.
Absolutely. But I think, Charles, on that point though, I think one of the big issues we shouldn't underestimate is the lack of awareness amongst doctors. So John Ioannidis is, in Stanford, professor of medicine, statistics, very famous guy, scientific integrity, very, very smart. He wrote this great paper, which I recommend all your listeners to look up because it's free online. It's called How to Survive the Medical Misinformation Mess. And he gives, a number of reasons why we have this problem where most of the research is not reliable or not helpful for patients, and all the different factors behind it.
Zombie trials.
But he says the main reason that this continues, this health misinformation mess about the fact that most scientific research is not good quality or reliable, and therefore we don't change the system, is that most doctors are unaware. He makes the case that most doctors are unaware. So once people become aware, then they start thinking differently. So I think don't underestimate that. We are in a bit of an echo chamber, because we are more enlightened people. We've had our own journeys. We've had our own, our own curiosities taken us to different places. We're more open-minded. We are acting with integrity once we realize what's going wrong. But remember, most doctors, I want to think of the best of people. I think most people want to do the right thing. They're just not aware of it, Tro.
Yeah, I think that's true. I think doctors want to do the right thing. And also your system says, look, if X number of your patients don't have a colonoscopy, they don't have this, or they don't have that. Our job is to inform and say, look, here's the risk, here's the benefit. If you don't do a colonoscopy, you could die of colon cancer. Yeah, I can't force my patient to get it because I, hate colon cancer. So I think when we get to that point where, it's so strange. I mean, some of us are a little bit older. We remember you cannot be paternalistic in medicine, right? You need to give the patient. Now you're saying be paternalistic. You have to be now.
Exactly.
We've swung the pendulum all the way back to where it was. It's crazy.
So I think I want to talk about this a little bit. I want to go back, in medicine, I'm faced with these, there's a place in between low risk and high risk, right? Patients, right? When it comes to heart disease prevention, when it comes to even vaccines, like I may be very eager to get somebody much older with much more comorbidities who's exposed to COVID in the middle of a surge. I may be very eager to consider an experimental vaccine with limited long-term data, right? And the patient wants it, right? So, and then I have the opposite, which would be, let's say my 9-year-old son, right? Who's healthy and has no, real issues, and may be more likely to see an adverse event. Right. And same thing with statins. So you have this dynamic where there's a high risk people more eager. You may be interested in an intervention. And then the low risk people who have no business even thinking about it. Right. Yeah. And, with statins, I'm going to go back to this patient I brought up who's somewhere in the middle. And I don't know that even the best data has the answer. Yeah. I don't know that even the best data has the answer. Now, if this man who I saw was 100 pounds heavier, like when I first met him 2 years ago or whatever, or if he didn't reverse his diabetes, which he did, right? Maybe I would be very eager, I would be very eager, just like his cardiologist was eager to put him on the medication, because now his risk is like huge. But
the only thing I try to add to that is that you be eager, but as long as he knows. So the problem is a lot of these patients go away with the illusion of protection, right? So we know some patients think, oh, my cholesterol's low, it means I can eat what I like and I'm fine. or they've been told as long as your cholesterol is low enough, you're never going to develop heart disease, right? So it's about empowering information. Whatever they decide to do, whether they take the pill or not, just make sure they're fully empowered with that information. They know exactly what the deal they're getting.
Yeah, well, exactly. That's it. So our visits, and the problem is to do that, to empower patients. Do you know how long it takes? It takes time. And it requires me to know, what the old paradigm was, what the current paradigm was. It requires me to have insight. Yeah. And I think, so you say most doctors would do the right thing. I don't think they're capable. Yeah. I don't think, you understand what I'm saying?
I know what you say about the time issue. Now, I've been doing this for quite some time. And I agree at the beginning, it takes longer, but I can do this, in an NHS consultation where I've got 15 minutes with a new patient, a new referral. I get this conversation in and they're out. And, so with time, the more you do it, the more easier it gets. And we can theoretically be able to have these conversations quite quickly. We can, Tro. I think, the bigger lifestyle stuff, I think, sometimes for some people, it takes a much longer conversation and they need support. So it's not just about the initial conversation about this is what you need to do. They need some extra support when they leave the consultation room, right? Whether that comes even from a psychologist potentially. So that, but I think that the conversation, you can have that potentially in a short space of time, but it's about getting used to it, knowing the stuff. I mean, for me in statins, because I've been looking at it so long, I'm very quick. I know literally, but there's not much there, right? It's less than 20% risk, 1% chance. If you've had a heart attack or stroke, 1 in 39 for non-fatal heart attack, 1 in 83. So it's all there. If you're elderly, if you're over 75, 1 in 446. It's ridiculous. How many older patients are taking statins? It's unbelievable. And that's when we also now know that high cholesterol in the over 60s seems to be protective against an early death. Right. So, there's a lot of stuff, but it's a big shift in the paradigm. And it needs to infiltrate itself within undergraduate and postgraduate medical education as well, so that all doctors can then start having these conversations. So you're right. It's not straightforward. It needs all of that information to be disseminated in the right place.
And I want to come back. You mentioned Ioannidis's work, and you mentioned being very critical. In his most recent study, I think the one you're alluding to, not the most recent, but on the paradigms in medicine, he analyzed the clinical trials along with John Carlisle from anesthesia, from the journal Anesthesia. And he found, I think it was an astronomical number of studies that were zombie trials, basically unregistered trials that were most likely falsified. And I think the problem is docs like you and me and Brian and all of us, right? We know the games pharma plays, right? But we don't understand that there's a whole nother slew of games. And so when I'm seeing studies on potential alternative, treatments, right, for public health issues that are ongoing, like, we're looking at data now from ivermectin, we're looking at data for fluvoxamine, we're looking at data for steroids and antibodies. I think we have to still maintain that high degree of critical thinking.
Absolutely. Absolutely.
Brian, how do you feel on that one?
Yeah, I just think we saw it happen before our eyes. We saw these fraudulent trials get published in our biggest journals, and then you lose, and they were absolutely fraudulent. You think, well, who's the editor? And then, really with the FDA panel, it really has struck me with this Dr. Rubin saying, we're not going to know. How are we going to know if the vaccine is killing people until we use it? I'm like, heck, could you imagine if you're building airplanes and you go, well, we haven't really had time to do safety inspection, but we'll see if it flies or not. Go ahead and get on. I don't trust that. And you're at Harvard, you're at the cream of the crop, and you're just saying, we got to try and see what happens. And I mean, to me, it's like, it just defies logic that you don't say, let's just step back. Let's look at our clinical experience, because we've used Chantix, we've used Zantac, we've used Bextra, all these drugs that have been taken off the market that they said this is going to revolutionize, this is going to save lives.
I think if everybody started with a default as well, Brian, I think in terms of cultural mindset for doctors, all industry-sponsored studies should be seen as marketing until proven otherwise. Everybody think that.
Especially when you have to do Freedom of Information Act and they won't release the data. Let me look at the data, then I can kind of smart people like you can look at the data and say, okay, let me just look at the absolute numbers.
You should say to them, if their studies are so good and their drug is so great, then release the data.
Of course. Of course.
So when they don't do
just
that,
like anything,
get suspicious, like, well,
Yeah, it's a really, and for people listening, Tro and I, at the end of the year, I think I have to settle up with you, Tro. We take a loss on the podcast, right? We do this because we love it and we want to, because we know we could reach way more people with a podcast than we can just sitting in our exam rooms. But the point is, we're not sponsored. There's nothing wrong with being sponsored on podcasts. So I'm not saying it's wrong, but when you look at the ads around your news station and you look who's paying these people,
Exactly.
and you realize like, hey, if I'm getting a lot of money from Dr. Malhotra, I'm not going to say bad stuff about his book, right? Yeah. And
Absolutely.
so you have to trust the integrity of the person. The head of the American Diabetes Association stepped down. She did low carb. She got better. And then you sit there and go, okay, I'm funded on this side by pharma, this side by big food. And don't get me wrong, I'm not anti-industry. I'm not anti. There's good people everywhere. But the point is, like, when you're beholden to people, so you're not going to say bad stuff about someone who's paying your bills.
Absolutely.
So it's a problem. And if you say, well, I can possibly work for them later, so I'm going to help them out here, and then they pay me back. And when we get into this cronyism, we're in big trouble. Because we can't trust anyone. Like, even if it's totally above board, you still say, well, is there a possibility that, he's paying to come on to talk about his book, that kind of thing. If I get a kickback on every book you sell, I'm going to push it like crazy, right? But if I don't, and we don't, then we say, hey, look, this is something we believe in, and we love everything you stand for, and we want to support people who are doing the right thing.
No, sure. And actually, just on the books thing, it's interesting. There's a bit of a misconception out there. So I've written 3 books. They've all been officially bestsellers. They've gone into whatever bestseller list. But I've not made a single penny off the sale of any of my books. Not a single penny. So most of what people don't realize, if you write a book, is you get like an agreed advance. The publisher then, once they make the money back from the advance from the sales, after that, they then will pay you 8% of whatever, right? So that's not happened from any of my books. And that's fine. For me, it was just another medium to get the message out there. But people sometimes attack us, or people say, oh, well, he's just trying to sell a book or whatever. It's like, okay, fine. But actually, no, that isn't the case. And also on the books thing, very briefly, what I was thinking about this issue about books. So we have a textbook of medicine. No one's, so some doctors may want to say, okay, well, so-and-so is trying to sell a book and that's it. But they don't talk about the fact that the people that have written their textbooks of medicine have made lots of money from their medical textbooks. They're not talking about that, which I find very strange.
El Salvier, and they're just to talk about that, and I want to bring it up because those same publishers literally took down somebody's, I forget who it was, maybe Dr. McCullough or somebody, wrote an article, and they took it down and said, we're going to reevaluate this article, and they get after peer review, after the editor's review, published, put online, that publisher decided its right to exercise its right to re-examine things. So yes, they are companies who make tons of money, basically privatizing information.
Yeah, and I think the other thing is these people who, like Dr. McCullough that you mentioned, like, this guy's been a stalwart. I mean, this guy has been the cream of the crop, and then he speaks against what the popular thought is. Ian Nadi's the same thing. If you look back at his predictions at the beginning of this whole thing, he was spot on. And everyone said he's lost his mind. The old man's gone crazy. He's doing crazy stuff. Look at Dr. Unwin. I mean, they said he was killing everyone. Now he wins Doctor of the Year. All these kind of things. You look and you say, gosh, sometimes the paradigm has to change. We can't just attack everyone who has a different view. We have to listen and say, okay, let me think about this.
Absolutely.
Could these crazy guys be right?
Dr. Malhotra, thank you so much for coming on. Guys, the book.
My pleasure.
A Statin-Free Life. I'm going to say this again. I get no royalty from this. We have no commercials. We have no interests behind this podcast. It is completely not for profit. So when we get somebody on like this, it's because we believe in their message and we believe in who they are. And his book is, I think, one of the best. Makes something very simple and easy to understand for the people who have been given a script for a statin and I want to question what's going on. So I cannot, one, I cannot thank you enough for coming on. 2, I cannot thank you enough for being the person that you are. You give me courage. That's the truth. And you inspire me to be even more cavalier.
And Tro and I hardly ever agree, so this is pretty amazing. But no, we agree on a lot. Actually, we agree on more stuff as we get older and start learning from each other. But really, the fact you've lost both your parents and you continue to fight, you keep going forward. You're respectful and you go, look, let's question this. Let me give you the data. And I think it's so critical. I mean, you really, I don't say hero very often, but I would say you're a hero to us because you were the lone, like Jason Fung's a hero to me because he stood up and said, hey guys, we're singing this wrong. We got to look at it differently. And he got criticized and they say he was nuts. And then he's the keynote speaker a couple of years later. So I think being able to, I think for a lot of docs out there, we have to be able to weather this storm and let people say you're crazy for a while until they start understanding what you're talking about. And you've done such a great job and such a great representative of saying, look, I want to help people. This is what I went into medicine for. And I think when you have integrity like that, we have to tap into that. We have to learn. We have to be motivated and say, look, do I want to step? Because Tro and I talked about it because I said, Tro, you know what we're getting into, right? If we do a low carb podcast, but so many doctors and so many patients, so many people have been helped. You go, it was worth the risk. It's worth the risk if you're doing the right thing, you know, and your motivation's right. So
yeah, people don't understand that. We got called quacks, and you shouldn't be talking about this stuff.
You have your license revoked for discussing the possibility that diet could affect mood and depression, anxiety, and stress. And that's, you know, and I think the big thing that we could all agree on too is that we're learning that metabolic health, the key is to be as healthy as you can to survive anything that comes at us, being healthier. And that's what public health hasn't really addressed. We're not addressing that, saying, hey, look, here's what the data is showing. You know,
and quality of life as well, right? That's the one thing most of these drugs for chronic disease can't do. Maybe they'll improve some outcomes further down the line, but statins don't improve the quality of your life. If you're lucky enough to get a side effect, the only thing they're going to do is make your quality of life worse. And we want to, you know, we're all going to eventually die, but we want to live the healthiest life we can for as long as possible.
Yeah, and you were the pioneer lifestyle. Watch your stress level. Go out and enjoy life. Laugh a little bit.
Yeah,
you know,
absolutely.
Have a cause that you believe in. All these things that we're kind of just jumping on your coattails, saying, this is true.
Laughter. I mean, listen, simple stuff, right? As Charlie Chaplin said, a day without laughter is a day wasted. So let's go back to the basics.
One question for you. One question before we go. One last question. Who is the right person to get a statin? Who's the right person? Tell us the right person. Because everybody's going to say, this is the anti guy.
The patient,
tell me the right person first.
The patient that wants to take it once they've been fully informed about their benefits.
There you go. Perfect.
That's the right person. So that could be anybody. Yeah,
100% agree.
Low risk, high risk, heart attack, no heart attack. The patient that wants to take the pill once they're fully informed about the benefits of the statin.
And any medical intervention that we do, any medical advice we do, it's the same thing. Right? There's some people who say, look, I can't do this. I'm not going to do it.
Same applies to heart stents, diabetes drugs, blood pressure pills. Absolutely. And in fact, I cover a lot of that, you know, briefly in the book as well about, you know, the basics for understanding who's benefiting from high blood pressure, for example, as well, like the cutoffs, etc., and what you can do instead. So it's all there. But thank you guys. No, thank you so much. And, you know, keep up the great work. This is really important stuff. And, you know, you talk about, you know, being called quacks and that kind of stuff. Take it as a backhanded compliment. You know, it was Mahatma Gandhi that said, first they ignore you, then they laugh at you, then they fight you, then you win.
Bingo. Man. And we'll end with that one.
Yeah, we'll end with that one. Yeah, that is a great quote. That is so true. So thank you so much. And everyone, hey, thanks for our Patreon supporters. We do appreciate you. It makes me have to pay Tro less at the end of the year and everything. So we appreciate you like sticking with us and listening to us, and really the support. It really, bringing someone like this to us it's incredible that Tro and I, two knucklehead primary docs, get to talk to someone like you of your stature and your in the history of medicine. You will go down in the history of medicine as a hero. I get that is something I can guarantee you for standing up for your patients and what you believe. And I think all of us, to some degree, some of us are maybe not as vocally, but it is an honor to have you, and thank you. And for everyone, you're listening to greatness here. We're not in the presence of greatness very often, and we appreciate you being here.
Very kind. All the best, guys. Take care. Talk soon.
All right, have a good one. Yep.
Bye-bye.
Absolutely.